Welcome to AETCM, the Emergency Medicine channel. Today we'll be discussing a case of a pregnant woman who ended up with seizures. Can you begin, sir?
Yeah.
So there's this 28-year-old female patient who underwent IVF conception secondary to infertility.
Okay.
And but she was brought to the ER with seizures. So in our initial 10-second assessment, patient was having active seizures, and airway was not patent. So in that case, all we did was shift the patient's uterus to the left lateral, manual shift of the uterus, and we put her in a recombinant position and then she already had an IV cannula, access. So we gave 2 mg of Medas to deal with the seizures, and because we'll deal with that later. So then apart from that, we put the patient on a high flow oxygen mask. Respiratory rate was 28 cycles per minute with a saturation of 94% in room air. And then air entry was bilaterally equal, no signs of aspiration. Circulation wise, she already had 2 large bore IV cannulas, and heart rate was 84 beats per minute with a blood pressure of 200/110. So with this, disability wise, she was having active seizures, but following that she had a post-natal confusion, and then pupils, however, were bilaterally reactive to light. Exposure wise, she was having a normal body temperature of 98.6 degrees centigrade, and blood sugar levels was 114 milligram per deciliter. So far we had an actively seizing patient who was shifted from the labor room to our ER in view of seizures. So by the time she got in here, her seizures already got terminated, and then she was in her post-ictal confusion state. So the things that we had to deal with was one, seizures, and the second was her blood pressure.
Okay. So we have an 28 years.
28 years.
What is the gravida that she's
30 weeks, 4 days gravida.
30 weeks, 4 days gravida. And anything specific about pregnancy?
Yes, sir. So she is a primary gravida who had been married for 7 years. So because of unknown cause for fertility, she was going through multiple fertility treatments. But this time she conceived through IVF. So she was transferred a frozen embryo which split and became 4. So she was carrying a quadruplet pregnancy.
Okay.
But so far in her 30 weeks of gestational age, she was not noted to have any gestational diabetes. She wasn't even noted to have any pregnancy-induced hypertension or anemia. No previous pre-eclamptic history also. No past history of seizure also. But because this was, and she had her LMP was in the month of August 15th. EDD was supposed to be in the month of May, 15th of May. But because this was in the month of October, she had threatened abortion history. She had bleeding PV. So following which she was on November 11th, she underwent cervical encirclage.
Okay.
So, and then because this was a high risk pregnancy with multiple gestation and also had a past history of threatened abortion, she was admitted in our hospital in the month of February itself on 24th as safe confinement.
Okay.
So patient did not present with any complaints to the ER, only for safe confinement. And in 2 days of uneventful stay in her hospital, she was taken to labor room for magnesium sulfate drip because she was planned for an elective LSCS.
Okay.
But while the magnesium sulfate was on flow, within 30 minutes of that magnesium sulfate infusion is when she developed first paresthesia in the left upper arm, then her neck, following which she had severe neck pain and a headache. And after that, patient doesn't remember what happened, but patient was throwing seizures. So that's when she was shifted to ER.
So let's at this point, let's discuss what are the common pregnancy related hypertensive emergencies that we'll see. So where we will place this patient, because we have pregnancy induced hypertension, we have eclampsia, preeclampsia, we have other hypertension which is carrying over to the pregnancy. Already she is a known systemic hypertension. Now she has become pregnant. So where will we place this patient actually?
So this patient, she's a direct case of eclampsia. Generally, there is in pregnancy induced, patient can either have a pregnancy induced hypertension or can have an overt hypertension. Overt hypertension is wherein patient already has a pre-existing systemic hypertension, but that shoots up during pregnancy. For pregnancy induced hypertension, it is defined as patient patients with blood pressure of more than 140/90 on 2 different occasions, but measured in a span of about 4 hours, but after 20 weeks of gestational age. So this is pregnancy-induced hypertension.
So this is pregnancy-induced hypertension.
Then
whether to call it as she was receiving magnesium sulfate. So whether what is the indication of magnesium sulfate here?
So sir, for magnesium sulfate in obstetrics point of view, there are only 2 indications. One of the patient has an eclampsia, that is pregnancy-induced hypertension with seizures. So in that case, we go with magnesium sulfate. They have a different Zagreb regimen, Pitcher and Zagreb regimen. Then the other indication is fetal neuroprotection when we are suspecting an imminent preterm birth, like in this case, wherein she was planned for an elective section within 30 weeks of gestational age. As an indication for fetal neuroprotection, we give magnesium sulfate.
Also, maybe for a high risk preeclampsia, also maybe we can give magnesium sulfate. But routinely, these are the indications. But here we need to clarify that she never had any hypertension history. So, but she was receiving magnesium sulfate for neuroprotection. So that is the reason why she was given magnesium sulfate. So basically, this patient never had any hypertension. The first presentation itself, she is having an seizure presentation. So the straight away she is presenting as eclampsia pregnancy.
Yes,
so that is what has happened here. So how will you deal with the seizure part? Primarily the seizure part, and as you said, seizure part and hypertension management. That is the key. Stabilizing the airway, breathing, circulation. Once she is out of post-ictal phase, her airway will be patent. That part will be taken care of. So how will you manage this hypertension and manage the seizure aspects?
So, sir, since she's a 30 weeks pregnant, so she'll have a gravid uterus. In that case, the first thing that we do is to manually displace
lateral displacement
of the uterus, and then we place her on a recombinant position, put her on a high flow oxygen.
That's all we have done.
And then give magnesium sulfate as a
we can treat like eclampsia. We can treat like for the seizure management, treat like eclampsia. Eclampsia management. What is the definitive treatment for any eclampsia?
Termination of pregnancy.
Termination of pregnancy. So that part is very clear. Eclampsia management is termination of pregnancy. Ultimately, she should be taken for an emergency LSCS. So that part is clear. Now coming to the hypertension management. So what are the challenges in managing the hypertension?
So this patient will fall under hypertensive emergency because there is an end organ event in it. So in this case, we will go with the beta blocker. IV dose of beta blocker is given as 20 milligram, and we can also repeat the dose following.
Which beta blocker you will?
Labetalol, sir.
So it's a beta alpha blocker, 1:7. So alpha beta is 1:7. It's a beta and alpha blocker also. Okay.
Then we give a 20 milligram IV bolus, and then after 15 minutes, we'll repeat the BP, and if needed, we'll repeat the bolus, following which we will start the patient on an infusion at 12 to 25 ml.
So what is our target BP reduction?
So in the first 1 hour, it will be 10 to 20% of the patient's present blood pressure. After we have attained the target, for the next 5 hours, we can bring it down to 140/90.
Okay, so that is within the first 6 hours, we should have a very good control. And the initial rapid reduction, we can do it in the first 1 hour. That may be the rapid reduction in the sense a 20% reduction. That only we are anticipating. Suppose it is 200 by 100, whatever BP you have said, what our target will be somewhere around 160, 170 systolic BP. That will be only our target. Okay.
So
what was done for her?
So in this patient, we, after managing the part, the magnesium sulfate was anyway on flow, so we continued. We in fact gave a bolus of that 4 gram IV bolus. Bolus has to be given within a span of 15 to 20 minutes. And then we have to repeat the dose if need be. And then we can start the patient on continuous IV infusion as 1 gram per hour IV infusion until the patient is taken for delivery. And then also we can continue it after 24 hours after delivery. So this is how magnesium sulfate is given. And if needed, benzodiazepine in order to, short-acting benzodiazepine in order to terminate the seizures right away.
Okay.
And then we will look for hemodynamic stability, and then blood pressure, we gave IV bolus. But sometimes seizures itself can shoot the BP up. So we'll have to, again, instead of rapidly correcting it right away after giving a dose, we'll have to recheck the BP after seizures has been terminated, because this patient has no past history of pregnancy-induced hypertension also.
So any role for your levetiracetam, all those drugs in this patient?
This patient, there is no role, sir, but this patient was given
So ideally, you speak, you want to terminate the pregnancy,
Pregnancy.
and the seizure part will be taken care of. But that is the ideal thing that needed to be done. The routine use of antiepileptics is not warranted actually in this case, especially unless and until you have another cause that you are not thinking in terms of a pregnancy. Suppose that blood pressure was normal and there was no other evidences, then we might think of adding an antiepileptic agent. Otherwise, routinely not needed. Imaging.
In this patient, since she was pregnant and termination of pregnancy, so CT could not be taken. So we imaging except for a chest X-ray with abdominal shield, there was nothing much that was taken. After the termination of pregnancy is when the patient could be taken for CT or an MRI to find the etiology for pregnancy. But most commonly, it'll either be a press thing unless she has a bleed.
What is the new terminology for the press? Reversible posterior leukoencephalopathy syndrome. So RPLS, reversible posterior leukoencephalopathy syndrome. So that is the terminology that I have given for previously. We call it as posterior reversible encephalopathy syndrome. So now they have made this way, reversible posterior leukoencephalopathy syndrome. So that is the newer terminology that we can use. So basically, what will be the presentation of press or RPLS?
So there will only be MRI findings, but patient will have
clinical
seizures.
findings. Clinical
Patient
findings,
will have
seizures,
and headache.
Headache and visual.
Blurring of vision.
Blurring of vision. Basically, it is posterior reversible encephalopathy syndrome. So this will be more in the occipital region. So what is the problem in the occipital region?
There's a occipital oculomotor center.
The main ophthalmic center is there. So
Mm-hmm.
the ophthalmic center will get affected, and as a result, they can have blurring of vision, diplopia, and all those things. So that will be the presentation. The patient will be very much anxious. What is happening? Whether she has lost her finding. So as the name itself says, it's a posterior reversible. It will totally reversible. Once you control the blood pressure, that is totally reversible thing. So only thing is that this pregnancy lady and all are very high risk for developing this reversible posterior leukoencephalopathy syndrome. So our target will be to bring down the blood pressure. 25% in the first 6 hours would be ideal, but maybe a rapid reduction, since the patient had also had a seizure, a rapid reduction of blood pressure. So you said regarding labetalol, what are the other agents that we can use?
Esmolol can be used.
Esmolol, hydralazine.
Hydralazine can be used. Then NTG.
The common thing is the NTG. The frequently used one is NTG. 5 microgram per minute you can start with until 200 microgram per minute. Titrate depending upon the blood pressure. So Fendalopam, all those drugs can be used, but the commonly used infusions will be labetalol and nitroglycerin infusions. So the key idea here is that you need to get the obstetrician help to terminate the pregnancy. Simultaneously, the blood pressure should be maintained in such a way that it should be reduced up till 20 to 25% in the next 6 hours. Okay. So what was done for her?
So in this patient, while we were dealing with the seizures and also hypertensive emergency, we involved the obstetrics team, and then we gave her steroids because
fetal maturity,
for fetal maturity, beta methazone was given 12 mg IM, and then she was taken immediately for termination of pregnancy. For LSCS, and she ended up with 4 live birth. Out of which 2 were kept in NICU for mechanical ventilation, but today they are extubating the babies. So all her 4 babies are fine. And all the 4 babies are fine, and today she is recovering also. Okay. She has regained her full sensorium. She doesn't remember obviously the seizures, but she remembers the pre-ictal event that happened. And hemodynamically stable, no further seizure episode, and BP is also under control.
Suppose you wanted to intubate her in the ED. She is not regaining her consciousness. What are the drug selections that you will do at this point? Which all drugs you will avoid? Which all drugs you will prefer to give in this patient?
For drugs, again, there will be pre-induction, induction, paralytic agents.
So I just want to know induction agents. And paralytic agents is very clear. You can use rocuronium. So induction agent, which one you will select? Propofol can be an ideal agent because it has got an anti-seizure property, and already there is hypertension. So it is one of the best drug will be propofol. Avoiding will be ideal will be ketamine, which will again increases the blood pressure. Then avoiding etomidate, again it can cause a high chance of myoclonus, but if you are giving it with the midazolam, the chances are not very high. So ideal drug will be propofol and previously thiopentone. It is again a very good agent, anti-seizure medication. So selection of agent should be done appropriately for this patient. So our key aim will be to bring down the blood pressure and terminate the pregnancy. So termination of the pregnancy is the basic treatment. So that is what you need to know. Anything else?
So uneventful, yeah, that's it. Then pre-eclampsia, that's it, sir.
Okay. Fine. Thank you.